before we get into that, we're going to start out with a quick networking activity. So how we're going to do this today is speed networking is what we're calling it. So you can find someone that you don't know or don't know well, and just spend 2 to 3 minutes talking about really whatever you want. We do have some prompts that you can start with if you're having trouble. What is one thing you're hoping to learn or take away from today's session? What's a fun fact about your role, your team, or company that others may not know? Of course, you can talk about whatever you want to talk about as well. So we'll spend 2 or 3 minutes doing that with one person, and then we'll do another quick switch, taking about 5 or 6 minutes total for networking. All right, any questions? Okay, ready, set, go. Oh, and for those of you online, you can do this in the chat. Okay. Zoom, you know, Sorry about that. I was muted there for a second. Okay. Next up is the main presentation, and we've got a great presentation today. I'm really excited about this one. Today we've got Dr. Brooke Sweeney from Children's Mercy Hospital to talk to us about pediatric obesity medications. And I think really these medications apply to many populations, not just peds populations. But Dr. Sweeney is the medical director of weight management services at Children's Mercy Kansas City and is a leading expert in pediatric obesity care. She's board certified in internal medicine and pediatrics and obesity medicine, and is a professor at the University of Missouri, Kansas City School of Medicine. Her work focuses on obesity pharmacotherapy, treatment approaches for children with special needs or genetic obesity syndromes, and bariatric surgery for youth with severe obesity. She contributes nationally through the American Academy of Pediatrics Institute for Healthy Childhood Weight. And I've known Brooke. Brooke, you've probably been at Children's Mercy 11 years, 10 years, 11 years. And I've been here about 10 years. And so I've known Brooke for a long time. And we've really gotten to know each other over the past 2 years because we've started a research project together, examining some of these same topics. And it's been a real joy for me to get to know more about her and about the clinic. And so today this is going to be a real treat for all of us, I think. So please, Brooke, come on up.
Use arrows, I'm assuming.
Yeah, I think.
Okay, great. Good morning, everybody. Thank you so much for being here, both in person and online. And it really is a pleasure to be back. I've been here and spoken before, but it's been quite some time. And I will say this landscape, right, of how do we treat children and adolescents with obesity has really changed over the years. I've been in this area now about 17 years. And it's just been so exciting to see all of the different building layers, right? And so I pulled in some old slides, and I'll talk about those because I was sort of reviewing a little bit for myself of like where we've come and how do these layers come on top of each other to just continue enhancing what we can do for families and children. This is my amazing clinical team, many of them who also do research, as Robin mentioned. It is a real blessing. So my biggest disclosure is that I'm spoiled, that I work in such a fantastic area where I have alongside with me psychologists, social workers, dietitians, nurse practitioners, nurses, and other physicians, as well as physician scientists and PhD researchers. And so I'm really in a unique position, right? In that I'm on the front lines helping take care of patients, but surrounded by a network, and also more greatly surrounded by you all, right? Knowing what is happening out in the community and the lines that the Center for Healthy Lifestyles and Nutrition draws. So we're going to talk a little bit more about obesity as a disease with a specific weight set point and what that means. We're going to talk about medications, but particularly how those are integrated, right, with intensive lifestyle, again, that layering. And then how do we monitor folks, right, for success and safety when we're using these treatments, whether that's lifestyle alone or with more advanced treatments. CPG there at the bottom is the clinical practice guidelines. So those were updated also by our own Dr. Sarah Hampel, who is also at Children's Mercy in 2023. The guidelines before that were from 2007. And then you'll hear me reference a guideline in the middle there, which was an endocrine guideline in 2017. And so again, we've just continued to learn more, but specifically because obesity is a chronic disease with escalating effects over time, a life course approach to the identification and treatment should begin as early as possible and continue longitudinally through childhood, adolescence, young adulthood with transition into adult care. And so again, this is why all of you are so important. I was just talking to someone who helps with certifying childcare centers and making sure that they're safe, right? These are, we start as soon as possible in whatever way we can. And this is a question that I start with. This is a slide I borrowed from one of my colleagues, Dr. Shad Smith, who does adult weight management, has been doing it longer than me, who runs our Midwest Obesity Society here. And I felt like this was a helpful way to understand that in your body, with all of the hormones and regulators, there's this tug of war that's going on that really is trying to keep your weight right there in the middle so that that flag doesn't actually move. Which means if you restrict calories or increase exercise, your body makes adaptations to prevent you from losing weight on purpose. Because if we lost weight without anything stopping us, we would die, right? So there's actually so many mechanisms that prevent weight loss and then also prevent sustained. And so some of them are listed there. Metabolism, right? As you lose weight, your body actually decreases how many calories it needs to conserve energy. And that remains, happens in bariatric surgery, happens with regular lifestyle-induced weight loss or with medications. Your hormones increase. You become more hungry. High caloric foods become more tantalizing, more interesting, right? What you hear out in public now, food noise gets louder. And then you have decreased fullness because your body is trying to push you to eat more. And then the second piece is that unfortunately, once you develop the disease of obesity, but particularly severe obesity, it tracks through your life, right? So that set point goes up too high, and then it just stays there. Okay. And that doesn't matter if you develop obesity at 2, 10, 15, 50, 70, right? That once you're up there, it's much more difficult to move that set point back down. And so this is from the very old Bogalusa heart study, right? If a child has obesity, 100% of them will have obesity in adulthood, for the most part. That's what they saw. 88% have more severe obesity and 65 the most severe. Okay. And so the other way, besides the tug of war, some people talk about it like a thermostat, right? That you have a thermostat in your house that's trying to keep at a stable temperature. So if you go and open the window, your thermostat turns on to bring that temperature back up with your heat, right? Close the window, temperature comes back down. But again, the goal is to keep that temperature in the house stable. And so that's what we're talking about here. So how do you talk about that with a family, particularly with a young child, right? So that's sort of the next piece of this that's really tricky in our line of work, because a lot of people still will come to us feeling either A, very frustrated because they've tried a bunch of things and nothing's worked. They feel like no one's believed them, right? That they've said, gosh, we don't actually eat that much. We exercise pretty well and nothing's changing. Or I've tried, but my child is so hungry, there's actually nothing I can do. If I pull things back, they're getting up in the middle of the night and getting food or hiding things in their room, right? And so all of those are indications. So we say, or one of the ways to talk about it, it's common for people coming to have experienced very little improvement in weight status despite trying to lose weight. This is because each person has a body weight set point where the body maintains and defends that weight status. And in folks who have obesity, that's too high. So when you try to make changes in eating or activity, the body tries to resist the weight loss, which leads to increases in hunger or whichever specific thing they might have told us they're struggling with. And there's lots of things that play into it. Genetics is one, right? Very challenging. Learned a lot more about this. There's a few monogenetic or one gene kind of differences, but most of the time it's just a whole bunch of different little genes that are promoting, as well as epigenetics. So changes in your genes that happen either while your mom's pregnant or shortly after birth or otherwise. Age, metabolism, and stress. We all know the impact of stress, right? So carrying extra weight is complex and it's not anyone's fault. We've already covered that. I'm just going to skip, but that's, it's much more complex, right, than calories in, calories out. And so when those clinical practice guidelines came out, they really emphasized understanding those underlying genetic, biologic, environmental, and social drivers that are risks as the foundation for the evaluation of treatment in children. And then this is a recent article that was really fantastic talking about weight bias. So we really struggle with expectations for everyone around what we should look like in many ways, and weight is one of them. And so folks often experience both their own internalized weight bias, right? That what have I done wrong to deserve this? And sort of internalizing those external factors that might have said something about the fact that their weight was or wasn't okay, as well as institutional and otherwise. I think you hear a lot about it in the media these days, which I hope is a good thing in the sense that maybe we're improving, but I'm not 100% there yet. But we really want to keep person-centered care in the middle, right? And making sure we're checking ourselves as well as our environments to dispel myths, making sure those environments are set up that are comfortable for people of different sizes, weights, and developmental needs. Education, you guys are here today learning, but we do lots of teaching to make sure that we stay up to date because this field is moving faster than many fields that are out there. So we can share accurate information. I can't tell you the number of folks that still come having experienced being with a healthcare provider who's just saying, you should just eat less. Why aren't you just eating less? How come you're not exercising enough? And that's really the end of the information that they've gotten, even in the healthcare system. And then autonomy is very important as well, right? You want to meet folks with what they need and want. Does not mean when someone has a certain weight that they have to do something with regards to their weight. They do need to manage health in general, but that does not necessarily mean weight if that's not what they want. And then we are frequently advocating, again, out and about, to make sure everyone has access, another large challenge. Want me to move it closer? Sorry, thank you. And so we think about what have our patients said to us and reasons folks may feel safe versus not feeling safe sharing or coming to us. Generally, what I hear patients want is to be heard, believed, and want treatments that match their goals. Liz Paul is a really wonderful woman who is part of the Obesity Action Coalition and an advocate who's a mom as well as a patient herself. And so these are a couple of her quotes that, you know, this is your work and your career, and you might be very passionate about it, but this is my life and a different ballgame for the patient with obesity. I never get to take it off. And then when bringing her child to a new care specialist or a new location, I'm not sure if I will need to protect my child from the clinician or if they will be an ally. And so just thinking about that extra burden, right, that you're dealing with for folks who are trying to get treatment for this disease. Therefore, in those guidelines, they really re-emphasized more fully understanding the implications of obesity as a chronic disease, understanding the physiologic impacts of social determinants of health on obesity more completely, and knowing more fully that weight bias and stigma is pervasive and harmful and can be a barrier to treatment. The 2007 guidelines kind of talked like about a layered approach where you would always start with lifestyle, for example, and just specifically calling out, right, no benefit to watchful waiting. So that's kind of that Bogalusa study where once it develops, we don't, like, kids aren't going to just grow out of it, right? That they're going to need to have some sort of support to figure out why that's happening and then direction to make a change. Obesity and comorbid conditions need to be treated concurrently, right? So we'll talk more about what those comorbid conditions are, but we see very similar ones in pediatric patients as we see in adults. We'll have lots of evidence, which is great, and structured supervised weight management interventions decrease current and future eating disorder symptoms. So that's been a hot topic, right, as all of these have come out. But if you think about it, for example, if you have a body that is having lots of hunger, like we were just talking about, right, and not being able to avoid, and you're taught to ignore those signals and just not to eat, that is not a pathway to healthy body, mind, spirit, right? Healthy relationship with food over time. Whereas if you intervene and can turn down the volume on that, then we can learn to listen to our body and trust our body so that we can eat and drink and exercise and do the things that we need to do. Obesity can be an indicator of structural inequalities like unjust food systems, health inequities, environmental and community factors, and genetics and obesity promoting environments, life experience combined with these inequities all contribute to overweight and obesity. So we were just talking about that in our Get to Know You, right? There's work for everyone to be done. It's not possible for any one of us to address this issue, but to figure out what's your area and just do the best that you can supporting, and all things matter for this. It's a relapsing and remitting disease. So there's going to be times where weight's going up or going down, or life is more stressful, or there's more challenges with a comorbidity. But that is the life course, unfortunately, of this. Therefore, folks being surrounded, right, in a supportive community, access to the care they need, free from weight bias and stigma, and supported both by primary care and their community-based services is very helpful. Common comorbidities that you guys know about, right? Hypertension, type 2 diabetes, fatty liver, and high cholesterol. We see all of these already in kids. And in fact, even very young kids. So seeing abnormalities in lab values in our 2 to 8-year-olds who come to see us. High cholesterol, LDL, low HDL, so low good cholesterol, high triglycerides, liver enzymes, right? So that's one of your early indicators of dysfunction of the metabolism, and then blood pressures. Many of these kids have multiples. We also have difficulties with mood and depression, right? Sleep apnea, low oxygen at night, increased pressure in the brain, so that's idiopathic intracranial hypertension, abnormalities in periods, PCOS, and then orthopedic issues, right? Not growing correctly, either too fast or too slow, or abnormalities of the growth plates that make the bones more brittle. So that's the hip that can have sort of separate at the growth plate, and then blounce where you have that curving of the legs, all related to carrying extra weight when you're young. You guys know very well the behavioral strategies, very good data, very successful, extremely helpful. And critical for all body sizes, right? So once we have severe obesity, these things are important for health, but they are unlikely to lead to weight loss. And we'll talk more about that. Children with overweight and obesity do benefit from health behavior and lifestyle, which is child-focused and family-centered, coordinated by a patient-centered medical home, involving pediatricians and other healthcare providers like dietitians, psychologists, nurses, exercise specialists, and psychologists, like I mentioned that we have, families, schools, communities, and health policy, right? So we need all. And here's your layers. So this is also from that CPG, that we need the ongoing assessment. We're going to use motivational interviewing, helping families be able to be in that shared decision-making process and letting us know what they're needing. And then your intensive health behavior and lifestyle. And then on top, for some, layering pharmacotherapy and surgery as needed. This is from the Obesity Medicine Association, same idea, child and family at the beginning, in the middle, with all the different choices. And here's ours from Children's Mercy, right? So very similar thought process, either pillars or but remembering that child at the center. And it's a spectrum. Having to add medications or surgery is not a failure, it just means your disease is a little harder to treat, right? And so really important that families understand that those are tools that are available, especially surgery kind of falls into that category that people feel like, oh, anything but surgery. We do surgery down to 10. So it's very useful, very helpful, and often curative for a long time for the kids that get that. Definition of health behavior and lifestyle is very important, right? This is not eat less and move more. This is how do you implement those changes, and how do you do that in the context of whether or not you do or don't have any of those intensive medication or surgery being done as well. And it's lifelong. That's hard for kids and families to understand, is that even if we're helping to bring the disease into remission, right, so weight goes down, you still need to stay in treatment, still need to stay on medication if that's what we're doing for most of them, right? That this is a life course approach. And so here's our set point. So how do you know if lifestyle alone is working? It's a really key thing to think about, right? So I gave you the extreme on the one side, which is ignore your hunger and just don't eat. That is not working, right? It doesn't work long-term for folks. Whereas, for example, let's say sugar sweetened beverages, right? Anyone who's tried giving those up, often you actually see decreased hunger, decreased craving, decreased, right, craving for other sweets too, because you've changed your palate. You've changed what those foods, right, may or may not have been manipulated to do, i.e. override those normal signals for your brain. Also true of salty, fatty foods, right? Those increase hunger and craving. So if you can pull those back, then often the food noise will also be quieter, and then you can allow that change. Okay, so that's what you're looking for to know if it's working or not. Not working looks like trying, and we're sneaking in the middle of the night, right? Is another example of that. More tantrums, more distress from the child. So when we're doing that, what it's not, right? Caloric restriction, energy in is just energy out by itself. Eat less, move more. And then sort of your list of different things, which I've already hinted at. Okay. I didn't mention improved sleep, right? That's another one. Sometimes they have obstructive sleep apnea. They're just not sleeping well. That also drives hunger, right? And so you can flip those things around. Mental health, less stress, less hunger to go with that, less emotional eating. Post-pregnancy is a time that for some, the weight loss is relatively easy post, right? Because your body's trying to go back. That is not true for everyone. And then bariatric surgery and effective medication. All right, so we're going to dive into meds. Any questions before we go? Okay, so I do a lot of teaching around the country for folks on how to use these medications. And so this is pretty high level. I will try to, we're going to have time for questions at the end, but you hear a lot about it. So I think it is helpful to start kind of figuring out what's going on out there. What's the landscape? So this is what I was talking about for how long I've been in this end of things that have changed. So 2010 is when our first injectable came on the scene. So that was liraglutide, which is Victoza or Saxenda, a daily injection, and it was approved for type 2 diabetes in adults. So that's kind of your mark for what's out there. Before that, we had phentermine, right? You hear a lot about it, still used. We still use it in kids. It's great medicine, can be used long-term, even though not officially approved to use long-term. And then if anyone heard fen-phen, right? So that was sort of the way back. So fen-phen is a combination of phentermine plus fenfluramine. Fenfluramine was the problem, and it led to cardiovascular issues as a side effect that caused some valvular disease. Okay, therefore pulled from the market. What that meant for this development is, number one, there was a long desert with nothing for additional medications. And the FDA put in regulations to say all medications being studied need to also study to make sure that we're not causing issues with the heart. And what we have seen in these medications is the opposite. And I think you guys are hearing that. Not only do they help with weight, they have benefits on multiple systems in the body, including the heart. So it's actually flipped the other way, which is actually super exciting. Even though it took us a long time to get there, we now have medications that are actually getting at the underlying and are protective of kidneys, protective of liver, protective of heart, protective of lungs. So that's a game changer, right? And so for that reason, they were started to be tested in children, right? And we are seeing similar benefits in kids. 2012, the combination of phentermine and topiramate came out for adults. That's Qsymia. 2014, dulaglutide comes on the scene, which is Trulicity. 2017, liraglutide is approved to support cardiovascular health. Semaglutide shows up, so that's Wegovy, Ozempic for type 2 diabetes. 2019 is our first purple, so that is the pediatrics. So once medications were approved for peds, that's 2019. So we are 7 years into this now. So that was liraglutide for diabetes. Then you can see the development there going forward for obesity in 2020. And then setmelanotide, I'm not going to talk about today, but it's up there in the middle under 2020. That is one of our specific medications for genetic single gene disorders of obesity, as well as Bardet-Biedl syndrome, also life-changing for those populations. Semaglutide approved for cardiovascular, dulaglutide for cardiovascular. So all three of them early on the market showed benefits for the heart. Semaglutide for obesity, 2021, and then tirzepatide shows up. So tirzepatide is Mounjaro and Zepbound. Another huge change in that medication is extremely potent, rivals bariatric surgery in the amount of weight loss that you can get. And then 2022 is when we have all the purple there approvals for pediatrics. So that's the other big pediatric year: semaglutide, phentermine, topiramate, and dulaglutide. And then the CPG comes out that we were just referencing, so 2023. And so they were trying to review all of these things for many several years before. And then all of those medications came on the scene right before they were about to publish. So quite a heroic effort. Most of this new 2022 data was included in those. And then 2024, I don't know if people, this was a big one, was when tirzepatide got approved for obstructive sleep apnea, separate from obesity. And so it sort of continues to change that landscape of approvals for insurance companies. But again, just for adults, it's in black there. And then 2025, several other things. That's when you see the benefits for chronic kidney disease, fatty liver, and then tirzepatide, actually right at the beginning of 2026, was approved for type 2 diabetes in pediatrics 10 and older. So a lot is happening in this area, which is why I do think it's helpful, right, to kind of get a sense of that. This is the way I frame things, because to me, it makes more sense when you're thinking about what % of weight loss might you get. And lifestyle, orlistat, and metformin are all similar. Orlistat I didn't talk about because we don't use it very much, right? It binds up fat and causes greasy stools. Kids don't like to use that, but it is still on the market. Works, but only if you're on a higher fat diet. And then with that 2 to 5% weight loss, you see benefits in glucose and triglycerides. 5 to 10%, right, is kind of that holy grail that we talk about. That's how you get metabolic benefits. True in pediatrics, it seems, as well as adults, but that's an adult percentage. At the bottom there, though, you see also quality of life. So that is usually when families, including children, start saying it actually makes a difference in their life if they can lose up to that 10%. And that's why those GLP-1s and then the combination medications made such a difference, is because those helped with lifestyle as the foundation to allow that level of weight loss. And then semaglutide comes on the scene. It is actually the first one that showed improvements in quality of life in pediatrics. And so really had to get to that 15% weight loss for pediatrics to see it. And then full remission of type 2 diabetes. Bariatric surgery leads to remission of type 2 diabetes, is a better treatment for type 2 diabetes than any medication that I can offer. Tirzepatide may be rivaling that, but I'm not sure that's exactly the case. But you do have to lose a significant amount of weight, right, for type 2 diabetes to reverse. This is the old slide I talked about that I pulled out from my talks pre the 2023 guidelines. And a couple of things I think I'll draw your attention to. This is kind of giving you that idea of how I think about things. The blue bars is the % of the population that has those weight categories. So it's just to remind us that even though you hear a lot about obesity in pediatrics, most kids still have a healthy BMI between the 5th and 85th percentile. And it is in that layer that the lifestyle is so critical. We want to keep people at a healthy BMI, right? Because we talked about as that transition happens, it becomes much more difficult to treat. And so that's where all of this comes in. That's so important, is access to healthy foods, kids learning to like and eat healthy foods, exercise and enjoying it, all those great things, as well as mental health. And then as you go up, we layer on additional treatments that are available for folks. And that's kind of what you see there. The majority of those, right, in different medical settings. And for sure, those top 2 tiers, very small percentages of patients, right? And so just to remind you, when you heard what areas I specialize in, I'm in that very tippy top. And so that's my perspective. Those are the kids that I see are the ones that have the most severe disease, that they've tried everything else by the time they're getting to me. And those are the most frequent, right, that are going to be on medications. Orals. Metformin, hopefully most people know about or know someone who's been on. It is approved 10 and above. For diabetes, we use it younger, off-label, and is super helpful in helping to reverse some of that insulin resistance to go back to sensitivity so that their bodies are functioning more normally, as well as many kids are on antipsychotics or other mental health medications, and it can cause weight gain and it can counteract those effects. Topiramate, also our friend, it's been around forever and is approved for seizures down to age 2, which means we have safety data down to age 2. So this is my one that I use for my little guys that you saw in those pictures, who are coming with those very, very high levels of obesity, very, very hungry, waking in the middle of the night, temper tantrums that last hours, hitting them, friends, hurting themselves, that sort of thing, right? And families trying to make changes without a lot of success. Is approved for obesity as part of Qsymia with that phentermine combination we talked about. The reputation it gets are because at higher doses, you can see mental dulling or them just not quite being their normal perky selves. For families, anytime we're starting medications, particularly in pediatrics, the conversation is about, we want you to feel like your best self. We want these things that are preventing you from being healthy to get out of your way, i.e. hunger, cravings, thoughts about food. If it's causing side effects, we don't want that, right? So I already mentioned this. We can talk more after the talk about that's working. You're likely going to stay on it for some time. Therefore, just tolerating side effects, that's a no-go, right? And so that's how we always talk to families about this. And so if you get those side effects, you're going to wean off. So it's a growth chart for anybody who hasn't looked at these before. Your typical growth chart ends at that 95th percentile, where you can see those finer lines there. The growth charts for my kids have all those extra lines off the top, okay? So at a typical pediatrician office, what I'm showing you there with the topiramate, that wouldn't even be on the paper. Does that make sense? So like a mom wouldn't even be able to see that on like the regular kind of growth chart, okay? But this is a child who we used a little bit of topiramate, and look at the beautiful response. So that child is happy, less tantrums, not asking for food 50 times a day, waking up, being able to do the normal things that a kid wants to do. And mom is able to maintain those healthy changes at home and then having a high quality diet. Before that, right, that wasn't what was happening. Here's that combination medicine. So Qsymia is the name you hear on the market. Combination of phentermine and topiramate. Works on norepinephrine, reduces hunger, reduces cravings, can actually help with headaches. Topiramate does that. And increases the metabolism. So the phentermine part also boosts your metabolism. ADHD medicines work similar, right? So that's why you see kids on ADHD medicines who lose weight. Similar thing. We start at tiny doses. So 3.7 milligrams of phentermine. So this was really beneficial to me when it came out, realizing so adult doses for phentermine are usually 15 or 37.5. And so when a kid, you're starting at 4. This is actually for adults too, you start at 4, but just letting us know we can warm up, right? Start at a low dose and work our way up to find out what works. And then the topiramate doses are the same. And so there's your graph for kind of the weight loss that happens. Red line for mid-dose, phentermine, topiramate, orange for the low dose, and if you, high dose, sorry, that approaches that 10% that we talked about. Here's one of our patients in college on that with a 20%. So going from 140 to 120, again, above the growth chart there, BMI down to 34.5 there. Okay. Super happy with that response. Was able to go to college, oh, by the way, and do this instead of what sometimes happens at college for folks, right? And so the eating didn't get in their way. I put this one on here. Really, any ADHD stimulant can work as well if used in a healthcare setting in combination. But lisdexamfetamine also does have indication for binge eating disorder in adults. And so it is my go-to usually just because of that indication, but it's also approved for ADHD down to 6. And so sometimes instead of thinking about a phentermine, right, you might think about this medication if there's impulsivity or a diagnosis of ADHD, and even sometimes combining that with the topiramate so that it works like that Qsymia. There are several others, which I didn't cover today, but they're not used quite as often. These are the ones that I think you guys probably want to know about. So here's our GLP-1s, as they're called. On the list, liraglutide, semaglutide, tirzepatide. You've been hearing those names. Dulaglutide is not on this because there's no specific indication for Trulicity or dulaglutide for weight. Only approved for diabetes, but we use it. So this is what I was hinting at. So it's so exciting. These medications have positive benefits in all those areas. Cardioprotection right at the top, right? We know why that's there. Coagulation makes your platelets less sticky. Postprandial lipids, so decreases your cholesterol after eating. So your liver usually sends out cholesterol after eating. That's high triglycerides or other things. Helps improve that. Protects your pancreas, right? In that, your pancreas, for those that have prediabetes, it might be trying to spew out more insulin, working harder. Doesn't have to do that as much. So you can see beta cell recovery. Those are the cells that produce insulin. Inflammation. We all hear about that, right? That obesity is an inflammatory state. And so these medicines by themselves also increase inflammation in the adipose. Helps your brain. sort of for the same functions, improving vasculature, improving inflammation in the brain is where that's coming from, decreasing blood pressure. And then your kidneys, increasing natriuresis and diuresis means decreasing the extra stress on the kidneys, right? So protects your kidneys. This is a slide that is talking actually about, so the red would be your typical GLP-1s. The green is GIP, so glucose-dependent insulin-trophic polypeptide receptor agonism, GIP is what you hear out there, that is in tirzepatide. So that's the second molecule. So that has two molecules that work together, both leading to weight loss, as you see. Common side effect for the GLP-1s is that nausea and vomiting, right? So you guys have heard that. If you notice in the green, nausea decreases. So tirzepatide, Zepbound Mounjaro, is stronger by a long shot with less side effect. So that's what's particularly exciting about this. So it's more potent with less nausea and vomiting. Okay. Otherwise, we've talked about most of those, but like increasing insulin sensitivity on both of them, right? But it doubles that, which is why it's in the category of reversing diabetes. A long list of adverse reactions, common: nausea, vomiting, diarrhea, constipation. Constipation is actually more common than the diarrhea because it slows transit through the gut. So it makes food stay longer in your stomach, right? Which also means slows everything else down. So my kids who have short gut or other issues with constipation, I've had a couple that it got real bad. Which means, and you'll see this later, our number one recommendation with starting one of these with regards to lifestyle is water. Back to the basics. Please focus on drinking water 80 to 100 ounces daily. A lot of water. That's what your body needs. And then uncommon but very serious, pancreatitis, small bowel obstruction. Gallbladder people also consider serious, but it's over on the other side because that's actually a reaction to weight loss in general. So that is not specific to the GLP-1s. You just hear it a lot because tons of people are on GLP-1s. But a lot of people have to get cholecystectomies, right? Have a gallbladder removed. Many of our kids have had that as well. The second telogen effluvium is hair loss, right? True of all weight loss. Your body gets rid of extra things, which hair is one of them. And then reduce muscle mass. So that's where Dr. Shook and I work together, that there's this question of, are GLP-1s causing more muscle loss than other ways that you might lose weight? And we don't know yet, for sure. I personally believe it's related to weight loss in general, but that is just a belief. We don't actually have the data yet to know, okay? And so we do lots of counseling and monitoring to protect muscle, right? Because lean tissue for kids is super important. If you lose weight, but then you lose bone mass and lean tissue, I have done more harm than good potentially, right? And so that's not okay. The psychiatric complications are tricky, right? Because this population struggles in general. So when I see, so we talk a lot about it. We don't want mood to get worse. There's lots of conversation. Sometimes it's because one of their main things that causes enjoyment is eating, and then you take that away. And so that's really tricky when that happens. Often means we actually stop the medicine because the kids hate it. And okay, that's fine. If that's what's going on, that's just a different, shared decision making. But there have been a few questions around whether depression is actually triggered. I think it's more multifactorial, but we watch very closely. And then acute kidney injury, probably also related to the dehydration, right? Getting too dry. And then anything else? Eating disorders are mentioned, right? So frank eating disorder would be a relative contraindication too. So liraglutide, Saxenda is the name for obesity, Victoza for type 2 diabetes. For you all to realize, the way we talk about it is same active ingredient, different name and marketing and FDA approval. So it's super confusing for people, us too. Semaglutide, Wegovy for obesity, Ozempic is officially for type 2 diabetes. There is crossover in how those are used. Same active ingredient. So I have patients coming to me like, I don't want Ozempic. There's all these bad things I hear about Ozempic, but I'll take Wegovy. Okay, it's the same thing. But the marketing is such, okay? But as you can see, particularly for semaglutide, type 2 diabetes, MACE has to do with cardiovascular improvements, MASH, liver, and then chronic kidney disease. So improvements in all those areas also proven. And so a graph on a young lady that we followed a very, very long time, such that you can see each approval of each medication occurring. So started on topiramate and lisdexamfetamine, the lisdexamfetamine for ADHD. Actually had a really strong family history of eating disorder. Okay, so we talk about this all the time with families. We are very open. We want you healthy body, mind, spirit, emotion. We want you to feel good about your body. The body image piece is a separate track from the weight loss in the sense that you got to work on that separately. It doesn't magically happen by losing weight, right? And in fact, it's actually harder often because you know you're the same person, but everyone treats you very differently after you've lost weight. It's very clearly represented in almost all of our patients in bariatric surgery. Happens some for other folks too, but if you're not, and so they need a safe place to talk about those things and to understand that's what's going on. Started on liraglutide, actually a decent response to liraglutide, as you can see, around 15%. And then semaglutide came out and had a dramatic response to semaglutide. This child was very, very good with exercise, did weightlifting and softball, right? So very, very active, a really good, healthy eater overall. The bigger challenge was once these medications take away your food noise, it's hard to remember to eat sometimes, right? And so for her, we always talked very openly about it because of the strong family history, but it wasn't about restriction in the sense of trying to get skinnier. It's that she really just forgot sometimes. So would have to set timers to eat occasionally to make sure that she didn't miss those meals like she was supposed to. As she was losing, there was one point she came in and said that her ability to do her bench press dropped off a little bit. And so that's another thing we monitor, right? Especially for our kids that are really active, we want them to feel energized and strong, right? So we don't talk about weight as much as how's your energy level, how's your strength. And so she brought that up because we've been talking about it. She's known us forever. And so, in fact, she did have some body mass loss, some lean tissue loss on our little scale that we use. So we had to bump up her protein, right? Bump back a little bit her medicine so that that hunger would come back just a smidgy, right? And make sure she's getting enough protein, and then came back and that had recovered in the next few months, okay? And then tirzepatide comes on the scene, and so there that is, okay? And again, interesting, because I told you that tirzepatide can cause a lot of weight loss. For her, we're in the maintenance phase, right? So it's a very low dose for her. She had all along had a little bit of that GI side effect, just kind of some nausea that happened day one after the injection. And so that was part of the switch, in addition to, depends on your insurance, which one they prefer, but she's just on a low dose of that one. So there's tirzepatide, Zepbound, Mounjaro, okay? Also approved for obstructive sleep apnea in adults. And there's your graphs. And so this is what I talk about that is very, very dramatic to me. So semaglutide, Wegovy, you can see that bottom of the curve kind of heads to that 15%. I've hinted at this, but as you can see, once we came off at 68 weeks for semaglutide, weight's going to go back up, right? They did not make them fully go off for long enough to see the rebound all the way. It doesn't actually go all the way back to the placebo line at the top. Usually you can still maintain some percent weight loss, kind of depends. But for the most part, right, when the medicine's working, you have to stay on it. If you come off, all of those changes go back to baseline, to your previous set point. And then Zepbound, tirzepatide, right, all the way down almost to that 24% line. So another 10% for the weight loss. And then the bars at the bottom in the tirzepatide tell you what percent of people reach each of those levels we talked about. 5% weight loss, 10%, 15, 20, and 25. The most remarkable thing to me about the tirzepatide is essentially 100% of people can lose 5% on that medication. Haven't had that before, right? Because of course, sometimes you're not going to respond to a medication or whatever treatment, but it is quite potent. And then for the bottom graphs on the semaglutide side, a reminder that even some people on the medicine will gain weight. So that's this little blip over there, right? Some people still are not going to respond and will gain weight even on these medications. Very rare with tirzepatide, definitely happens with semaglutide. Insurance coverage, you guys don't need to dive into this, but as you guys know, this is a hot battlefield out there because these medicines are expensive. They're going to get less expensive over time, but right now that's very difficult. It does ruin budgets. We'll just say it that way. Both home, when people decide to pay out of pocket for them, which is why we had all of the compounded medications that were out and about, as well as to the insurance companies themselves. It's getting better, but it's going to be a while yet. So these are the comparisons of how much expected weight loss for each one. So semaglutide way up there, and the rest of them kind of more in that 5% range. Orlistat and metformin, similar to lifestyle percentages. But then if you pop tirzepatide on that, right, it's pretty impressive. And so not approved yet for weight loss in pediatrics, but it is one that when I go and talking to people, like, you all need to have a very healthy respect for this medicine because it knocks your socks off. It, even at lower doses, sometimes, like, kids will come back and I've just gone up one step, like to the third dose, there's like 7 of them, and be like, yeah, I'm not eating at all. Okay, wow, you're a super responder. Let us go back down, please. That is not okay. And so, right, we want kids eating and losing weight. You don't want to teach your body that the way to lose weight is to starve. That is not the way this works. And so that's a whole different thing. But you can imagine, right, a kid that's coming to you who their whole life has been told don't eat. That is a major mind shift to realize, like, oh, I'm actually supposed to be eating. Yes, you're supposed to be eating. Your body needs food, high quality nutrition, right? So we do focus on that, but they need to be able to eat. And then these are those comparisons of what percent of patients lose that 5% and 10% we talked about, right? Reaching those thresholds for changes in your other comorbidities and such. And so 70% for semaglutide, whereas more like 50%, 45% for phentermine, topiramate, and liraglutide. Phentermine by itself also can be quite potent, by the way. And then topiramate too sometimes. Like I mentioned, semaglutide increased quality of life in adolescence. That's the first medication that showed that. And then this is that brain stuff, because it's a little harder to put your head, for me to simplify that, even for me to get my head around that. But attenuates neural inflammation, right? So decreases inflammation in the brain to protect those neurons. So you can also think about it in a simple way, in the sense that if your food noise is less, then you have more energy to focus at school, right? Just like somebody with untreated ADHD, very hard to do the things that you need to do. You treat that, it gets better. There's a little bit of this happening as well. How do we manage side effects? Hydration, I mentioned. Smaller meals, smaller plates, eating slowly. So all these great lifestyle things, back to the beginning, right? Going full circle. Watching those fatty foods, it's not like you have to never have them, but they're sometimes really hard on your stomach, especially on a GLP-1, right? You can get nausea and vomiting, particularly day 1 and 2 after your injection. So my kid that eats 3 pieces of pizza day 1 after an injection is probably going to puke. And so hopefully that only happens once, and then they're reminded that they shouldn't be doing that. And then they sort of make different plans. Some folks actually have to be really bland diet that first day to feel okay, or use a meal replacement shake, other things like that. But we don't want you skipping, right? Small breakfast, and then eating every 3 to 4 hours, high protein, high vegetable, and fruit. Drinking fluids, you can use ginger and peppermint. And then we don't want that late night eating, right? Because you have slowed gastric emptying, so it just sits in your stomach all night. That feels gross. And then collaborative monitoring, back to the team, right? We want to hear if there's side effects, hear if there's worries, and then working with your mental health providers. We see folks frequently, every 4 to 6 weeks during titration, as we're increasing dose, spreading it out a little once you're more stable, and then watching back to those original things that I said. It should become easier to do the healthy things. You're seeing everything kind of clicking along, and that they're doing all those healthy behaviors that they haven't been able to do in the past. So it's not either, it's both. Intensive lifestyle plus those intensive medications or surgery that work together, right? And that, in fact, sometimes I'll ask the kids if they have family members on the GLP-1s, tell me what they're doing to take care of themselves. And I have some kids that are able to say, like, yeah, my mom's on this and she's not doing anything she's supposed to. She's losing weight like crazy. She's not eating her protein. That's not good. And then sometimes you have the opposite, right? That they'll really talk about eating those healthy proteins, fruits, and vegetables, and you'd be like, look, great, do the same. I put this up here because I just like to remind us, right? So again, back to eat less, move more. This isn't about just willpower. It's not about adherence or compliance. So we really try not to use those words. But then where does our personal responsibility come in and what does that look like? And so I've submitted the word agency perhaps is better, right? That agency means an action or intervention, especially as to produce a particular effect, right? So the patients do need to do things in order for these medications to work, right? And so it's not like the medication is magic, but it's not like they're non-compliant if weight's going up or they're not able to do the things, right? And so you're working together to make sure that. And then I've said this several times, but for kids especially, I really want them to get back to know thyself. I want them to be able to hear the normal signals their body's trying to tell them about what it needs to take care of itself. Mental health needs enough sleep, enough water, enough food, right? And then those positive connections with other people and to be able to listen so that you're getting the right signals. Hunger is one that's potentially been out of control for a long time. And so we integrate nutrition goals, physical fitness goals, and behavioral health goals, particularly once the medications are working. This is from an adult paper, but it's kind of that same idea, right? We're at the center. We want all those healthy bubbles to develop over time for folks. We do care for sure about developing healthy eating behaviors. It's a great paper by Eileen Chavez, one of our friends that's at Nationwide in Ohio. That you want folks to eat when hungry, eat intentionally, stop eating when full, positive body image, variety of healthy food, a range of different foods, and doesn't need to regulate emotions, right? Not everybody gets there, but we don't want things sliding in that other direction. And so we're monitoring for that very, very carefully, which includes restricting to control weight and shape, which is the way we used to try to treat obesity. And so that's where these come in and are so important. Unresponsive to hunger and fullness cues, eats to regulate emotions, compulsive eating, limited, inflexible food intake. So that's our kids with food selectivity or pickiness or autism. That's another area we work with. And then firm dietary rules. I never eat X. We don't want that, right? You want to be able to eat everything, but in smaller bits, listening to your body, right? A giant piece of chocolate cake usually makes your tummy feel yucky, but a small piece is great. Have that sometimes, and they should. So it's that same slide. We know it's working when we have decreased hunger, food noise, and cravings, improved sleep, improved mental health, hopefully improved exercise as well, though that becomes a tricky one for some folks, and that it's over the life course. Typical questions we get: how fast should weight loss be? Strategies that support maintenance, so not gaining weight back, and what's the optimal way to preserve lean muscle mass and prevent bone loss? So you heard those hinted at through the talk as well. Areas for research and things we talk lots about families too. Lots of new kind of tools to screen for folks. This is an adult set of recommendations that's just in here if folks wanted. I don't usually think of it that way, but the water we do in the sense of how much water to some extent for protein, but we're going to calculate it differently for kids. I mentioned this already. High satiety foods, a list of those because that's very helpful. And then here's that role of physical activity. So this is actually the beginning of that emerging data that a GLP-1 liraglutide plus exercise, you get more weight loss and better sustained weight loss. So you do them together. We screen with DEXA to look at, research is DEXA. This is a body composition, so a BIA scale that we use in clinic as a sort of less specific measure, but helps us, like I was mentioning with that young lady. We already talked about this. I'm going to open it up for questions. These are kind of more tips or different things, but I want to hear what you guys want to hear more about. So,
okay, let's give her a quick pause.
What do you guys want to hear more about?
Okay, yes. Oh, we'll open it up for questions.
Hi, I'm Lauren Crumley. I work for Clay County Public Health. What is your intake process like? Can families reach out to you directly? Do they need to be referred by a primary care physician? What does that look like?
Yeah. So we take referrals from primary care because we need them to be solidly nested with their primary care, and primary care does much of this. So we have also, just like training you as here, many primary care have also learned to use some of these medications as well. So we work closely with primary care, and so then they refer to us.
I've got a list of questions. So these things are probably, maybe some of you are thinking, this is, my parents are in town. So I was telling my dad, or we saw a commercial, I think, for a GLP-1, and my
Yes.
dad was asking me about it. And he said, wait a minute. So these kids have to be on these medications for the rest of their life.
Yeah.
So I had a response, but as a weight management provider, what's your response to someone like my dad?
So depends on someone like your dad versus my patient in the room. So we'll start with the patient in the room. And so what I say to families is that this is something that's been going on a long time before you came to me, right? And it's going to be going on probably your whole life, with times that we go into remission, right? And times that we have relapse or that weight comes back. I don't have a crystal ball. So you're not likely to be on this medication for the rest of your life, because I also know there's lots of new things coming out, right? And certainly not at this dose. But as long as this medicine is working, yes. And just like we wean the medicine up, if we were going to come off and try that, which we can absolutely once we get where you want to be, you're going to step down in that same process. And if symptoms come back, you're going to let me know, right? And so we do over time want them to be on the lowest dose of medicine needed. If you look at the studies for tirzepatide as an example in adults, it does look like maybe there's 10 to 20% of folks that can get more durable weight loss off the medicine. And there's ones coming on the market that actually do permanently reset your set point. So stay tuned. But for now, the truth is, yes, something, because we're treating an abnormal pathway that had been there to begin with.
Yeah, that makes a lot of sense. And, I think I've heard a lot of talks from our weight management providers, and the one that really stuck with me was you wouldn't tell someone who has hypertension that they should only be on their antihypertensive meds for a couple of years. Of course, you would want to manage their treatment for as long as they have their conditions.
Yeah. And I like hypertension as an example too, because we also want to do the lifestyle things, right? Like you got to do the exercise, the decreasing stress, and the watching your salt too, right? Even on those medications. But sometimes over time, you do need more medicine or a new medicine because your other one stopped working.
Yes.
I'm Cindy Lafferon with the Midwest Center, and I do very periphery research with Robin. I never heard obesity as a disease, and that was I just really like that. And I think it explained so much and made me understand it so well. So I just wanted to say that as someone, I think like your dad and someone on the outside of all this, it really helps you to look at this. And I think it's a great way to help many people understand what this really is. And just this theory too, like, yeah, you're going to be on this forever, or you have to treat this forever. So I really like that. Thank you.
You're welcome. Yeah. And that is relatively new-ish, right? So probably last 5 years, there's been lots of debate about the definition in that, in kind of for us, but it's a huge shift, right? And we used to, everything was excluded by insurance because it was seen as a cosmetic problem versus the disease that it is.
You briefly touched on this, but maybe if you could talk just a little bit more about access to these medications and insurance, and maybe specifically about how Missouri and Kansas Medicaid provides access, or what are the conditions for access for kids?
So we are very fortunate in this area. Kansas was one of the first states actually to cover these medications for obesity in adults, but also in pediatrics. Credit to their teams in figuring out how to do that. We would think their restrictions were a little bit tight in kind of how, but they're trying to prioritize, right, the medications for those who most need it. Because this shouldn't be used for I need to lose 5 pounds for my cosmetic whatever, even though we all know that certainly does happen out in the world. Missouri took a lot longer to discern, in my mind, but also covers these medications for kids and pretty much covered them with minimal restriction, leaving the decision in the hands of the providers, which with most medications, I'm 100% in favor of. For us, it made it a little bit tricky as those educating people out and about because it's a new field of medicine. These are new to a lot of people and knowing how to use them. successfully and safely does take some education, as you saw in the beginning. And tirzepatide, they did not even put limitations on that based on the FDA label. So we're allowing folks to use that in younger children. And they still do, for that matter. And so helping people understand, that's why I talk a lot about, hey, careful, it knocks your socks off, because it is really, really potent. And so it sort of begs the second question there being hinted at is, we now, as folks using these medications, can pinpoint almost a BMI for people, which is a scary place to be as a provider for a pediatric patient, which means it puts us in the position where people come asking for these because they want to get to a certain point, right? Whereas with your blood pressure, if you come in and you have a high blood pressure, but it's a little high, you're going to use a less potent medicine, right? And a lot higher, you're going to use multiple medicines or more potent medicine. People are wanting these for less severe obesity. So we're having to have these conversations even with pediatric patients and be very careful about that, because this disease has lots of social implications, right? And so that's the tricky part of it as well. Coverage, Missouri and Kansas Medicaid do. All other insurers, it sort of depends. And so we actually have a full-time pharmacy tech to do prior authorizations, because it is such a burden on our team to do that. And we have part of a pharmacist who's working with us at all times as well. And so those have been instrumental in being able to help families and navigate this changing field, even for Medicaid. Our pharmacist has been working with us just about 1.5 years, and we've had like 5 different changes to the Medicaids on both sides. And so even just keeping up with that and then re-educating has been also really tricky.
And I want to come back to your team in just a second, but how does Kansas and Missouri vary compared to other parts of the country in terms of access for like Medicaid?
So we are also very lucky both with lifestyle too, right? So Dr. Sarah Hampel and Deb, she's retired, it was really Markinson, have been working years and years and years in these states to get lifestyle coverage in addition to medication coverage. There are a few other flagship states where folks have worked on this, but we are in one of those places that really does see this as an integrative approach, does have coverage, always needs improvement, but for the lifestyle plus, right? So those 26 hours and the medications, but that is an anomaly, I would say, throughout. So probably, I have the slide somewhere, but I think it's around 20% of states maybe with coverage.
My question about your team was, I've learned that as access to these medications becomes more readily available, lots of different providers outside of weight management are prescribing them to both adults and peds.
Yeah.
And I've learned a lot about the difference when, a general practitioner prescribes these meds versus a prescription coming out of your clinic. Can you talk just a little bit about that? I mean, you've mentioned in a couple slides, but
yeah. So we are, again, in the Children's Mercy system, very fortunate. Most folks will come to us to learn the pieces, but even at Children's Mercy, so just as one example, if our sleep medicine folks, right, who are obesity medicine certified and are using these GLP-1s, they don't have the same access to psychology, social work, and dietitians that we do, right? And so they're relying on our supports of like, how do you quickly teach? And there are certainly people who, if you can quiet the food noise, they do know, and they can handle the more quick intervention type thing. But the reality is, as we've just talked about here, there is so much more to be done, and it does leave it more on their shoulders, that family's shoulders, to figure out how to get the additional support and resources that they need, which does therefore increase your risk, right? And how you're doing that screening and how fast people can come back. That is true even in our endocrine department, right? Because they're geared up for type 2 diabetes and then all of the other endocrine issues, not this one specifically, right? Which is actually quite different in the way you teach. And then thinking about folks out in the community, right? And so I call it the wild, wild west sometimes, because you just don't know kind of what resources folks are going to need. But it is where those communities come together, right? And it does help to know kind of what is going on out there so that people can come alongside, because there are resources, but it's just a matter of how do you actually hook folks together and make sure, for example, your dietitian knows kind of how, at least had some idea on the way you would counsel differently for someone that's trying to do weight loss lifestyle alone versus weight loss with medications or bariatric surgery. And so it's those kinds of ideas. But again, it goes back to coverage, that there's often not a lot of coverage for those other services and not enough mental health coverage and mental health access. Other questions? Yeah.
So as far as, and I'm Katrina, I'm a WIC dietitian for Wyandotte County. My question is like, how high does your BMI have to be for the trizepatide, and is there a number for that?
Great question. So officially, they have gone really just obesity, and which I think is a little tricky, right? So that's kind of what you're hinting at, is that where you saw my bar graph, I break it down to class 1, class 2, and class 3 obesity. Class 1 still can respond to lifestyle, because again, that's just 5 or 10% right there, and maybe a little bit of medicine. But some people are going to have more resistant disease or have more comorbidities that go with. And so that's what we're looking at, right? Is do you already have some insulin resistance? Is your liver already showing? Do you already have sleep apnea? Are you already having knee pain or other things going on, or the mental health challenges, right? And so then you can be more intensive, but it does, to me, mean you want somebody that's even more experienced, even though that's not normally the way you think about it, right? So that you can be monitoring and making sure how high to go on the medicine and how to have those conversations when, because we have this happen, right? That you're getting down into a normal range. And so I want them to plateau, right? To find their new set point, but they want to go further sometimes. And so that kind of discussion is really hard. And I think particularly hard when you don't have all the other resources around. And so there are some systems where the only people that would get to me is, like I said, those folks that are in that bariatric surgery range are very high. But I also think there's a really challenging group that are right there along that 95th percentile too.
How do you determine where you want their new set point to be?
It's a great question. The jury is out, so nobody really knows. But I think back to just like any other disease, right? Like you're not going to take somebody's blood pressure all the way lower than it should be, but you do, normal is okay as long as you are doing all the good behaviors, right? And so for us, really anywhere under the 95th is a happy place from my perspective, but also, as I showed you there was somebody that's still at the 120th and he was happy as a clam, right? Because he could now do all the things he wanted to do. And then you're watching their metabolic markers. So I don't usually tell anyone about where I'm trying to get them to. You're just sort of working with them to monitor and hoping that their mental health work around body image is happening at the same time so they can kind of handle wherever they end up. Most people honestly feel so happy, right? That when they've lost that 10 or 15%, like they're good, right? Because they can move more. They just feel so much better that it's kind of this, it's not everyone that we have that challenge with. Go ahead.
So this kind of can relate to children and adults, because a lot of insurances don't cover these meds unless you have diabetes. But if you have a BMI of 30 or above, I feel like you should still be able to qualify, because that's still a qualifying disease. But so yeah, how is that going to change? Is that going to do you know anything
so
where things are going with that?
Yeah, so it is going to change over time as the price points get better. I will say that, phentermine and topiramate are very inexpensive. And so a lot of our patients actually pay out of pocket for their phentermine, which is $15 to $20 a month. Topiramate's usually covered without difficulty and is in the same range. And so the orals aren't too difficult to get covered. So especially for folks that have, kind of less to lose. But the challenge is, even if your BMI is 40, they're still not covering it, right? And that is really, really difficult when that's happening. And that you already are seeing the comorbidities, particularly in our population, that's pre-diabetes, right? So their ANC is 6.4 instead of the 6.5 needed to diagnose diabetes, and you're still stuck. And so, do I wait and just let it drift above and not do anything on purpose so that then you can get it covered? So that's the place I think we don't want to be in. And so that's where I do think there is That's why the drug companies have pursued those other indications, is try to prevent that. But at the same time, everyone accepting that obesity is a disease is where we need to be. But the reality is so much would have to change in order for us to be able to afford these for everyone. And so that's kind of why we're going to hit this time when the price is at such a point that the economics make better sense. So it's not an easy answer. And there's many days that it's very difficult for our families. They can't get it covered.
And now kind of a question regarding my job. We do get kids where I wish we had a graph like you do where there's lines above the 95th, because we do see kids that fall in those lines.
Yeah.
Sometimes I don't even see their plot point on ours. Like it's even off the paper.
Right.
So I guess my question would really just be, tell them to talk to their doctor and, get a referral to be seen by Children's Mercy, because you guys obviously are the expert. Is there anything else that I should be referring them to, or really just their doctor?
So that's the right answer. And especially thinking here, and then, honestly, I normally then, and then you love them, because most of those parents, now there's different groups, but a lot of them already feel really bad because they're like, what am I doing wrong? Like, why is this happening to my kid, right? But for those, that's that early onset rapid weight gain, right? And you saw that in that little guy that then ended up on a little topiramate and stuff got better. What would have happened if we could have intervened a little bit sooner, right? Those sorts of things. And so that's why the earlier the better is still the case, that we don't talk about kids just growing out of it. But that little guy has had really high hunger ever since they were little. And so having the healthy foods available is super important, right? But going to require some sort of help in addition, right? And sometimes it's behaviors, sometimes it's uber pickiness, right? Sometimes it's impulsivity, like you just don't quite know what that is. But in our special needs clinic that we mentioned, I have a psychologist with us, Dr. Dreyer, so her areas of expertise are in autism and then that very young child, because they're a special group. And so we all talk about it nationally, and there aren't super great guidelines. In fact, they aren't even covered in these guidelines because we don't have enough evidence. And we don't have medicines that go all the way down. That's actually why I called out topiramate, because at least I know it's safe, but there's not actually an approval in that age.
And another issue we run into is sometimes we'll ask the parent, has the doctor said any concern that they're concerned at all about their growing? And they'll say no, or the parent just doesn't see a problem, at all.
Yeah.
And we're talking 20-pound weight gain from age 2 to 3 or something like that.
Yeah. I don't know how much, really good parenting skills are super important no matter what. I know teenagers, still really important. And so that is part of it that I do think is helpful if they're not ready to talk about weight. And that's kind of how we got in for our younger group classes, is sometimes we just talk about it as a parenting class instead of as a class for weight, because once you have good parenting skills, then doing some of these weight-based interventions is much easier, right? If you can set limits and handle a kid who, is screaming for X, Y, or Z. Sometimes Z is food, right? So that is super beneficial too. Yeah. Yeah, you're welcome.
Any other questions? Maybe we'll just finish, Dr. Sweeney. So 5 years ago was 2021. In 2021, we did not have any of the clinical trial data yet on any of these GLP-1s, which things have rapidly changed,
Yes.
quickly changed in the last 5 years. Where are we going to be in 2031?
Great question.
So not that you can have a crystal ball, but.
So there are lots of really exciting new medications in the pipeline. Like I said, some of them that actually do, have the potential to reset the set point with that continued innovation around early intervention and protecting organs. I think we're going to be in a new place from that perspective. However, there's going to be lots of things that are still the same, right? Because that's what I see when I look back 10 years ago in my presentation, is that we're all still going to be talking about how do we do all these healthy lifestyle interventions on a daily basis, right? I set my new goals for January, and 1 month was good, second month not so good, this month 50-50, right? And so that's not going to change, right? And the importance of connection and mental health And so that's my hope, actually, is that in 10 years, the mental health piece, that we're making a lot more progress, but the medications are going to be more precise. So the area I'm most interested in, separate from muscle with Robin, is phenotyping, or looking at how you find the right treatment for the right patient at the right time, right? Because if I knew that ahead of time, right now, I kind of have to just pick one and see which one's going to hit their right pathways in order to have the effect that I want. And so I want that precision to be able to say that and to be able to do it sooner. And that's where I hope I am, because then if you're changing that trajectory, maybe, particularly if it's prepubertal, can you switch? Because that's fixing something before they go through adolescent development. And is there a greater portion that then wouldn't need medication for the rest of their life, for example, right? Could you actually reset something by identifying earlier? So that's where I hope to be, Robin.
Okay. Thank you very much. Let's go ahead and stand up and give Brooke a standing ovation.
Thank you so much.
Okay, give me just a second to the rest of our slides up here. Don't tell my dad that I shout him out, give him a shout out in the presentation today. Actually, he's taking my children to daycare right now, so no, he's not logged on. Okay, all right, we're going to do just a couple quick updates from our team at the Kansas City Healthy Lifestyles Collaborative. We'll give you an opportunity to share updates from your organizations as well. First off, for the Kansas City Physical Activity Plan, we've got, of course, lots of upcoming meetings. Here you can see the meetings for school sector, business and industry, parks and recreation, and sport. I don't think we'll say anything more beyond for those sectors other than when these next meetings are. But we also have some specific announcements for some specific meetings. And Natalie, do you want to give a quick update on the sports sector?
Or Pete chime in if I forget something. April 8th, we're going to host an event here. It'll be kind of focusing on the momentum that's coming to town with the World Cup, and how community organizations can engage with that collectively. We had some meetings with KC26, and they kind of led us along the path of what they're like thinking about for a legacy project. And they wanted us to focus on coach training and development. So we're going to have a panel with a lot of great experts in that field here locally. Someone from U.S. soccer coaches. There is a FIFA panel for youth development, a council, and they're working on human rights projects in each of the host cities. So we're going to have one of the representatives from that Kansas City council. So we're excited about having them. I think that covers mostly the agenda for that meeting. Am I forgetting something? Okay.
Great. So capacity is somewhat limited for this event. So if you're interested, or you know someone who might be interested, feel free to scan this code and send that to them. Registration will probably fill up within the next week or two, I would say. So please sign up now. This is not just for like youth soccer programs. This is anyone involved in youth physical activity in the Kansas City region. I think will benefit from this workshop. Okay, healthcare sector. Katie, do you want me to say do you want to say anything specific about this, or just announce? Okay, the healthcare sector is a very, very active sector within the Kansas City Physical Activity Plan. So they've got their overall next meeting on Tuesday, the 14th. They also are restarting the billing and reimbursement subgroup of the healthcare sector, because there's been a lot of interest around that topic. So if you're interested in the overall healthcare sector or specifically in billing and reimbursement, you can see the dates of those meetings on the slide. Early childhood sector, I'll let Kelly give this update.
Yeah, we are close to doing our early childhood gardening workshop. We do not have the registration yet. It will be live at the beginning of next week, but save the date for May 2nd here at Kaufman. The gardening workshop will be around physical activity in the garden and early child care settings, as well as a hands-on portion that will include kind of provider comfort levels with gardening and how they could engage at each level, as well as some hands-on salsa gardens or pizza gardens that providers can take home with them. So if you are not in the early childcare group and are interested in receiving the registration link, my email is not up there, but come see me if you're in the room. Otherwise, you can sign up for the early childcare group or email me, and I can get you the registration when it comes out next week. Thanks.
And so just so there will be some in-person teaching here, and then you're going to go next door. Is that correct?
Right now, there will probably mainly in teaching here. Otherwise, we do have the opportunity to go across the street to the Discovery Center where there are beds, and we'll have a master gardener there to help questions around gardening. So.
Great. That's going to be an exciting workshop. Kelly and the rest of the team in the EC sector have really done a lot of work on this. It should be a really great one. So hopefully there's good participation, and there will be CEUs or CECs, whatever they say that again. 4 clock hours for ECE providers if you attend. So big benefit there. All right. We have a date for our June quarterly meeting. With the World Cup coming this summer, things are going to be kind of crazy around town. And so Kaufman is going to have limited access actually during the summer as well. So we're going to have a Tuesday quarterly meeting to get us in before the limited hours at Kaufman. So our next quarterly meeting is going to be on Tuesday, June 9th, 9 to 11. And I'm really excited to share this topic with you. It's going to be on health communication in the age of artificial intelligence. I saw this presentation last week at a conference, and it knocked my socks off. And I said, I've got to share this with our partners because kind of like GLP-1s, AI is here and it's going to be with us for the rest of our lives. And no matter what you think of it, good or bad, it's going to be a part of our jobs. And it is quickly changing how we communicate things like health and healthy lifestyles and other parts of communication. So this is going to really go over the very basic entry level of what AI is and lead you through what are some very advanced ways that you can use AI in your work. For example, I saw a video of someone communicate health information in Spanish using their own video, using a video of them and their own voice, but this person does not know Spanish. So they can create, using AI, a Spanish language video of them communicating about, this was, I think, HIV vaccinations or something like that. So this is coming. In fact, it's here now. So please join us for the June quarterly meeting. I think you're really going to like it. Okay. Are there any updates from any of our partner organizations that you would like to share with the rest of the group? No, everyone is doing great things. Don't be bashful. Okay. If there's, if no one wants to share anything, but you think of something later that you would like to share out to our group, please just reach out to either myself, Natalie, Kelly, or Katie, and we can include it either in our sector specific communications, or we can communicate it out to all members of the KCHLC. So with that, thank you so much for joining us today. We really appreciate it, and have a great, beautiful spring day.